Anyway, disclosures. Well, I guess I owe you an explanation. The last step, what does that mean? Well, that was the question that I was asked just a little while ago. I'm a little curious. What does that mean? Well, the last step in getting a kid out of the unit usually is getting that tube out and getting them onto breathing on their own. That's what this talk is about, getting that tube out. My disclosures, Declarant, I'm on its scientific advisory board, and Medtronic, I still have the royalty agreement with them. And very little of that will have to do with this talk. Anyway, laryngeal stenosis was a rare and obscure problem years and years ago. It was primarily due to infection and trauma, and today it's an ever-present concern in every one of our ICUs. Interestingly enough, it's the unwelcome result of our success in managing critically ill children as well as adults. Significant understanding has evolved about the causes of stenosis, the diagnosis, the management, and how we prevent it. And despite the advances of the last 30 years, including much better endoscopic diagnoses, radiologic imaging, better anesthetic management, the availability of cardiac bypass and ECMO, and improved surgical techniques, the management of laryngeal stenosis still is a significant challenge. The topic for today is very specific. It's acquired, intrinsic, short and long segment stenosis. We're not talking about congenital stenosis. We're not talking, and it's in the larynx. We're not talking about tracheal stenosis. Let's really stick to the larynx today. And by definition, there's several levels of stenosis we talk about when we speak about the larynx. You have supraglottic stenosis, where you have involvement of the structures, including the hypopharynx, involved with the narrowing, as you see in this circumferential burn consequent to a little adventuresome tonsillectomy. Here you have a glottic stenosis at the level of the vocal cords with an acquired web as a result of excessive surgery at this site. And then finally, a subglottic narrowing, the level down to the level of the cricoid from the level below the vocal cords themselves. So those are the three levels we speak about. The differential diagnosis in terms of the symptoms that this produces, which is stridor, are in children basically very simple: laryngomalacia, vocal cord paralysis, asthma, and croup. And those are fairly easy to rule out. Today, the primary 90%, 95% of the laryngeal stenosis that we see is from acquired from endotracheal intubation. There's other causes, but intubation is the primary cause. Now, intubation has been around in one way or another for a long time. There's talk in the Egyptian papyrus literature of using a reed to put into somebody's mouth to get them to breathe again. But the first actual drawings that I found was the 17th century aspirator used to blow air into the mouths of babies at the time of birth. And this 18th century device used to try to intubate folks who drowned and then inflate their lungs again using these leather bellows. But the real beginning of intubation begins with this man, Joseph O'Dwyer. He was a pediatrician working at the Foundling Hospital in New York City during the 1850s, 1860s, 1870s, and he was appalled at the enormously high rate of death consequent to diphtheria, which was raging through the New York City slums at the time. And these children who they saw typically died of an eschar formation at the level of the larynx that occluded the larynx. So O'Dwyer created these little intubation units made initially of gutta percha, and using a oral gag and a blind intubation forceps and they would intubate the children. Now, what this looked like is shown in these autopsy specimens. Of you can see the blind placement of the little cannula into the larynx, and then how the cannula was fitted in the larynx. Initially made of gutta percha, then eventually made out of steel. And the method that they used to do this was to hold the child upright. The mouth gag was placed into the child's, to keep the child's mouth open. The child was held by two adults, and the doctor, Mrs. O'Dwyer, doing the intubation himself. Then a photograph is shown how it's blindly placed, and this is how the kids were fed after the placement of the cannula. The idea of then intubating patients took hold, and the first recorded intubation of an operation done with using general anesthetic in the form of ether was by Sir William McEwen. Now, I bet you Rob can tell us a little bit about Sir William McEwen, the Scottish surgeon, and because of McEwen's triangle in the site that you're interested in, but give us a little background on him.
I might defer to Cher Albert, but he was, if I'm not wrong, Lister's successor, I believe, in Edinburgh, and he wrote about suppuration and the mastoid and intracranial suppuration as it related to the ear. Most notably from the Stanford point of view, we actually came and visited Stanford when it was in San Francisco in the early part of the 19th century. I think you may have come across that.
Yes.
Yeah, there's a picture of McEwen with Lane, right?
Oh,
Lane, of course, of Lane library fame, is a head and neck surgeon. Wrote the first textbook of head and neck surgery in I believe, in the world, not just in America.
In the world.
Was the first one.
1998. It's the first book about head and neck surgery.
Yeah.
But what is also very interesting with McEwen is that he introduced the burr to open the mastoid, and it was completely new. Because before it was a manual burr, and he used a dentist burr, and it's made really quickly all the operation. But he was not an ENT; he was mainly a brain surgeon.
But before there were brain surgeons. I mean, he was a general surgeon, but.
That's right. Now, just to show you the breadth of his skills, the operation that he utilized intubation for was for a younger man who's had an oropharyngeal tumor. That he felt that he could not operate on and maintain the airway with the bleeding that he expected. So the two of them practiced. He had a tube created. This is, keep in mind, this is before the time of that we knew about direct laryngoscopy. This was blind intubation. They practiced blind intubation in his office, and then after mastering the technique with the patient, they proceeded with the operation. He did the resection. I don't know the fate of the young man. He was in his 40s, but that was the birth of endotracheal intubation with anesthesia. Soon thereafter, other blind intubation techniques came into use. For example, this is a German device from 1900 showing a curved tube that was blindly passed, much as we do in some of our anesthesias today. But anyway, keep in mind, direct laryngoscopy does not occur until 1895. This is a consequence of an accident at a hospital where esophagoscopy was being performed. And inadvertently they got the esophagoscope, which was of a Michelitz type, using a prism to send the light down the shaft of the instrument. They accidentally got it into the trachea. Young surgeon at the time by the name of Alfred Kirsten heard of this, ran up, saw what happened, and realized, well, maybe we can get at the larynx, and direct laryngoscopy is born. And with the advent of direct laryngoscopy, and take a good look at Kirstein's laryngoscope, here it really doesn't look very, very different than what you guys are using now. The exception is that the light source is proximal. The light source is in here, and it's prismed down the shaft. You don't have distal illumination yet. But within 15 years of that, you do, in form of a battery-powered laryngoscope with distal illumination using a tiny tungsten bulb. This is 5 years after Chevalier Jackson describes the use of a distal bulb, tiny bulb for bronchoscopy. And then then during the World War II, the two main laryngoscopes that you still see being used in the operating room, the Miller with the straight blade, which is very similar to our laryngoscopes that we use for laryngeal surgery, and then the Macintosh with the curved blade are developed for intubating and giving anesthesia to soldiers in the field as a quick way of intubation. So this is the intubation side of the story. The second side of the story comes in ventilation. Now, there are crude forms of ventilation done. I have photographs that I didn't include here, but crude forms of ventilation dating back to the late 19th century. But ventilation on a large scale becomes a big problem worldwide, and particularly in the United States, with the great polio epidemics of the 1930s, 1940s, and 1950s. And as you know, polio affected not just the limbs, but it affected the diaphragmatic musculature, the chest muscles, and the consequence was kids couldn't breathe. And so they had these large numbers of external respirators, pressure respirators, that breathed for these kids while they healed. Most of them came off the respirators, some of them died, but this was a transition for these children back to health or semi-health.
Peter, I'm sorry, I don't mean to interrupt. Can I just make a recommendation? I just read a really wonderful book called Polio, an American story by David Oshinsky, which gives the whole history of polio, which is really interesting to our field, but also very interesting about the emergence of vaccine and virology and Sabin and Salk. And it won the Pulitzer Prize a few years ago, and I just got around to it, and it was terrific. It was really an excellent medical detective story. Sorry for the interruption.
No, this is great, because again, you see how big public health issues that sweep through history affect what we now do today. Bottom line is that this was a inefficient and not a particularly applicable way of treating trauma victims or victims of pneumonia or other illnesses that involve the lungs. And it wasn't until 1953 that Donald and Lord developed a simple positive pressure respirator and applied it to some neonates with some success. It's not until the mid-60s, and this is the time I start college, that in Australia, in Sydney, MacDonald, who was an anesthesiologist, and Stocks, who was a surgeon, put together this combination of ventilating somebody while intubating them, and the modern ICU was born. And I started medical school in 1971, and an ICU was the latest new thing at the time at Albany Med. So this was the birth of the ICU. And then the birth of the NICU really begins up the street at UCSF in the early 70s with the application of CPAP to the ventilation of the baby and obviously the emergence and the use of surfactants. All of a sudden we have an epidemic of children who have laryngeal injuries requiring tracheotomies. And the problem was, in the early 70s and into the 80s, was that these children, we could get them out of the NICU, get them reasonably healthy, but they were dependent on that trach. And we learned a lot in those times in terms of what the pathophysiology, what happened to that larynx. And what we learned was that initially there's edema, and nobody documented it better than Bruce Benjamin. He's also Australian, although these are my own photographs, but they're based, the photographs are based on his classification. But initially you get edema, usually involving the conus elasticus going from the edge of the cords down to the level of the cricoid. Subsequently, the mucosa breaks down and you get ulceration, and with ulceration of the mucous membrane, you get granulation to infection. With infection, you lose the mucosa and you expose the cartilage. With the cartilage exposed, this becomes chondritic. The cartilage itself is lost and replaced by fibrotic process that ends in your classic stenosis. And the stenosis can be anywhere from the level of the vocal cords all the way down to the cricoid, and of course can also involve the trachea, but we're not going there at this talk. Now, the prevention of this is obviously the most desirable, and this requires expert intubation, and shouldn't be done by the youngest member of the team, and certainly not before they've had some practice in simulation. You need to be sure you're using appropriately sized tubes, and you want to have a leak around that tube, usually at about 20 centimeters of water. Finally, that tube needs to be properly and safely and securely taped so that it doesn't move around with the movement of the child. This may require some sedation. We think, we're not sure, that reflux may have a component in inflaming the intubated larynx. And sometimes if the kid's larynx is not looking particularly good, use of antibiotics and steroids at the time of extubation can be applied. Finally, as a means, as a transition to normal breathing, Heliox and CPAP can also be utilized on the babies. But what's important to remember, and this is really profound, is that the great majority of kids are extubated without any trouble. Okay? This is, they're extubated without difficulty, without any consequence or any need for a formal airway exam. So who needs to be, who do we need to be worried about? Well, we need to be worried if there's no leak around the tube at the time the kids are intubated. If the kid wakes up and is stridulous, and it continues to be stridulous, not just in the first 10 minutes, but in the first 10 hours. If there's no sound at all, then you got to be really worried, because they're not being able to get enough power or enough air through the narrowness. If they're in obvious respiratory distress when you extubate them. And then more subtle signs like they're just not growing, or they're having sleep apnea because of the obstruction. So where do we begin in terms of diagnosis? Well, a good physical exam and listening to the airway is probably a good way to start. And you should see the looks I get when I take my hearing aids out and put the stethoscope to my ear. But it still works, and it's a good way to start the exam. X-rays are of some value, and most of us who are a little bit older in the room recognize the steeple sign here on a child with croup. On an anterior posterior view of the larynx, and here on a lateral view in what's called a Cincinnati exposure, which is high KB, you see the subglottic narrowing below the level of the pores themselves, which are right there. CT scans are particularly good for tracheal stenosis. I think less valuable for laryngeal stenosis, but it's amazing what we can do with radiology these days. And these are some 3D CTs and reconstructed and virtual bronchoscopies that can be done and to give you some semblance of what the problem that you're dealing with is. But the bottom line to me always is if it doesn't sound right, you look under the hood. Symptomatic children need an endoscopy. Robin Kahn likes to say, it's only a theory until you've looked. I think he's absolutely right. So how do we look? Well, we can look with a fiber optic laryngoscope, and in this case shows nicely a congenital subglottic stenosis on a child. We can look with the optical laryngoscope in a fairly normal larynx here, where we can examine the larynx properly with instrumentation, see the mobility of the arytenoids. both from the side in and the inside out. See the motion of the cords while the child is breathing, or through a bronchoscope where a child is more severely afflicted, as in this case of very severe tracheomalacia that requires a tracheotomy ultimately to deal with. And finally, microlaryngoscopy with a microscope is also effective, particularly if you're going to be treating anything with a laser or require two hands to work. We'll use this regularly. Now, in terms of the grading of stenosis, this grading system that's universally used and misused is Robin Cotton's and Chuck Myers classification, where grade 1 is 70%, grade 2 is 70 to 90%. Grade 3 is 90 to 99%, grade 4 is 100%. And you can see here's grade 1, you know it's a pretty good airway, getting pretty small, and this is, you don't want to have one of these, and well, this one requires a trach. But there's other considerations. You're dealing with a plumbing, essentially, that is consequent to the flow of a fluid. So the length of the stenosis matters, the maturity and the hardness of the stenosis, what's going on with the larynx, the functional components of the larynx, is there a loss of cartilage? And examining the larynx under anesthesia in the operating room really is what you need to do in terms of assessing the larynx properly. You can size the larynx at that time, compare the size of the tube that should be accessible to that larynx as is being done here, and assess rhythmic mobility, which we've shown. And what we typically see, we'll see edema at the level of the vocal cords or in the subglottis with ulceration. Now, early on, often we'll see these eschar forming at the lower portion of the larynx. And this is a 21-month-old with stridor 4 days after congenital heart surgery. And you can see the eschar, it's easily debrided, and then the site is painted with mitomycin, and then the process is repeated until the area heals nicely. This is 4 months post-op, and it's essentially a normal airway. And conceptually, the way I think of this is laryngeal wound care, not any different than our sinus surgeons do when they go in and debride a sinus after endoscopic sinus surgery to promote good mucosalization. Same thing works in the larynx and trachea. If that doesn't do the trick, we consider doing a cricoid split, an operation that never made any sense to me on it, to be honest with you. And I never really did any. But this shows you how the original concept came to be, where you split the lower 1/3 of the thyroid cartilage through the cricoid and then the first 2 tracheal rings, opening it up in this fashion. I figured if you're going to open up the larynx, you might as well do a real operation. So when we do this now is we take a little piece of the thyroid ala, crown of the thyroid ala, and use that. It's just about the right size to fit into this little space that we create to enlarge the framework. And we sew that in with 5/0 Prolene sutures. And you can see there's the site of the harvest. It's about 1 centimeter long. And when you create, you can see where it's harvested from. You can see the larynx is opened and the piece sewn in. It's not any different than a vascular patch. And this is that same child now 1 week after extubation. If that type of procedure doesn't work and the child is still requiring intubation, well then you can do laryngeal rest and retry an extubation, but ultimately a well-done tracheotomy in a child can be a life-saving thing and get the kids out of the unit. And in my hands, typically for a child expected tracheotomy in for a prolonged length of time, I like to do my starplasties, which I think are nice and safe and are easier to manage. This is a rare event. We looked at over 2,000 kids through our PICU at Cleveland Clinic, and out of those, 60 kids were intubated for more than 1 week. Only 9 of them ended up, about 14% with a trach. So tracheotomy is a rare event in the ICU setting. Now, in terms of managing it, that's we talked about the acute management. We'll talk a little bit about the long-term management. Historically, what was done was observation, and you just watch the child. Our forefathers figured out fairly early on that oxygen and humidity were very helpful, and the croup tent was thus born. This is a nice demonstration of such a device, I think, done to a good access. But here's a typical case. Here's an 18-month-old intubated for RSV at 2 months of age, now having recurrent episodes of croup. And when you size the child in the operating room with a appropriately sized tube, the child is just half size. What should easily go through this is a 4.0 endotracheal tube, and what goes through easily is a 3.5. So it's just one size down. This is a grade 1 stenosis. Best thing to do is just when the child is sick, antibiotics, steroids usually get them through their illness, and eventually this larynx will grow. For more severe stenosis, the historic treatment was dilation, and I've shown you pictures in my balloon dilation talk on the concept of dilation going back also to the 19th century. But here's a good example of what can be accomplished by dilation using the Jackson type dilators, the filiform dilators. You can see where you can go from here to here. Now, you can also do endoscopic microsurgery, for example, with a laser or with a sickle knife, lyse these bands of mucosa that are causing the stenosis, as is done here, and then apply mitomycin and Kenalog, and this is what it looks like several months down the road. Not cured, but gone from a grade 3 now to a grade 2 stenosis. The other thing you could do with these microflap techniques, which I think are technically difficult, where you make an incision in the scar band right here, then raise a mucosal flap distal to you and proximal to you, and then laser out the scar and then lay your flaps back down. I've always found that some part is never fully covered, but again, you can get similar types of improvement. Over time, successive dilations will improve the larynx for most children, not all. When sinus balloons came around about 2005, I thought these would make great devices for dilating up the airway in kids, and we tried these out and they were really quite good. We found that for short grade 2 and grade 3 stenoses, simple sequential dilations can be very effective. Here's an 11-month-old with stridor, history of prematurity, multiple prolonged intubations, multiple surgeries. Now he presents to me as failing to thrive. Not stridor, but failing to thrive. It's amazing what sometimes walks into the clinic. But it's clear grade 3 stenosis, which is short and membranous. And for this, you pass the dilator through there. And then enlarge, keep the balloon from water melon seeding away from you or toward you. These are powerful devices. We then paint the area with adrenaline initially, then mitomycin. If we can do it beforehand, we'd like to inject the site with Kenalog also, again, help with the healing. If we dilate several times, let me go on here. This is what it looks like 4 dilations later. We started here, and this is the airway afterwards. So again, you get really very nice results using balloons. But there's a limit to what can be accomplished endoscopically. If there's significant structural loss of cartilage, in other words, you've lost your laryngeal framework, And if the stenosis is long, involving multiple levels of the larynx, then endoscopic management so far is of limited value. And particularly if you need to augment the laryngeal framework with cartilage. Now, this operation of laryngotracheoplasty or laryngotracheal reconstruction was introduced by Robin Clonton working with Blair Fearon at the Children's Hospital in Toronto, Sick Kids, 1978. And this was the problem they were dealing with, the plug trach, which they felt was responsible for about 10% of deaths of kids who had trachs. Their initial operation was an anterior augmentation of the larynx using rib cartilage. This was a two-stage procedure where they put a stent in to support the graft and then subsequently removed it. Eventually, Robin went on to pioneer both anterior and posterior grafting and then one-stage reconstruction. I'll show you examples of each. The operation starts with a rib harvest where you expose the rib, usually the floater and the two ribs above it. We usually like to do it on the right side. And since I operate usually from the left with the residents and fellows, again, we go through the abdominal musculature to get to the ribs themselves, and then harvest the rib and then carve the rib. The carving of the rib is dependent upon the amount of the stenosis, the length of the stenosis, and your own particular aesthetic, I must say, of what you think is a pretty graft. My mentor, John Evans, liked these curved grafts. George Zalzal developed this graft where it's a boat-shaped graft with a flange on it that sits on the outside of the airway. And then this bishop miter type design meant to include the tracheotomy site. Usually this operation begins with a complete laryngeal fissure. Here's the thyroid notch, here's the thyroid notch. Today we don't go all the way unless the stenosis involves is a grade 4 stenosis, and you really need to split the larynx in half. Typically we'll go 2/3 of the way up to the level of the vocal cords. But this shows it fully split. You find where the cords are, where the ventricles are, where the arytenoids are, and you can identify those nicely in the interior of the larynx. And then you can graph the site of stenosis depending upon the amount of stenosis and the length of stenosis and the type of graft you've designed. I've been particularly partial to George Zalzal's design. It seems to make a lot of sense. You create the design of the graft that's to go into the airway, and then these flanges support it in the airway. And this is what it looks like when it's sewn in. Now, putting in a posterior graft used to be very hard. You'd split the posterior larynx to a posterior laryngeal fissure, splitting the posterior lamina of the cricoid from top to bottom, and then sew in a little piece of cartilage that you've carved out of the rib. Bob Ward made this operation easy for us. Here's the posterior laryngeal fissure, and you can see the edges of the cricoid. And what Bob designed was this, again, a flange-like graft where the flanges snap in underneath the lamina of the cricoid, and the graft with its perichondrial cover is facing the airway, and it just snaps into place without having to sew it in. Life becomes much easier than this. Used to be sewing these in was hard. So here's a good example of a 3-month-old with Downs post-VSD repair. Probably today I would dilate this, but show you what we did. 1 month after surgery, onset of stridor. We open up the larynx, take a little piece of cartilage. Here's it sewn. It shows the graft. Here it shows it sewn in place from the journal. And this is what it looks like 1 week post-op. And this is what it looks like 3 years down the road. You can see the graft nicely incorporated into the subglottis. Sometimes an anterior graft is not enough. Here's a 2-year-old born at 24 weeks of gestational age. age, has a great, was intubated for a prolonged period of time, now comes to us with a trach and has significant stenosis. You barely, you can't get anything through there, and just a pinhole. So for this, we do a complete laryngeal fissure, stem to stern, all the way down to the trach site. We then incise through the posterior part of the larynx completely down to the thickened cricoid, and then take two pieces of rib graft and then carve those into the appropriate shapes. Again, here's the drawings, here's the grafts, here's where the graft is taken, and then here's the laryngeal fissure, here's the endotracheal tube coming through from the pharynx, here's the posterior snap graft in position, and then the anterior graft coming down, covering the original trach site. This is a one-stage reconstruction. Child is now intubated for a week in the in the ICU, and then brought back to the OR, extubated a week later. This is what it looks like a week after the surgery. You can see the posterior graft is almost completely mucosalized. The long anterior graft is still healing into place, but you can see nicely how that boat-shaped graft is holding the airway in a nice round configuration. This is what she looks like 3 months down the road, and then we left. So laryngotracheoplasty has about an 80-90% success rate. The failures tend to be when we have circumferential loss of cartilage. So in other words, when you put in a graft, there's nothing to hold the keystone up. We continue to have lousy voices after these LTRs. Voices are terrible. And the emerging alternative is the criciotracheal resection. Here's a 16-year-old, 3 weeks of intubation following a self-inflicted gunshot wound. He lost twice with in this Russian roulette game. Actually came in a wheelchair, unintubated, into our clinic and he's got these vocal cord granulomas, but more significantly, he's got this high grade 3 stenosis at the level of the cricoid. So for him, we went ahead, did a trach, and then proceeded to do a criciotracheal resection. It begins with the removal of the anterior lamina of the cricoid cartilage, detaching the stenotic segment from the posterior lamina of the cricoid, and removing the entire stenotic segment. So here is the lower edge of the thyroid ala. Here's the cricoid cartilages on either side. Here's the endotracheal tube coming in, and the cords are way above us. And here's the stenotic segment below us. And that's being removed here. Gives you some idea of how tight that was. And we're cutting into normal, healthy trachea, which is then released. And you create the posterior anastomosis. Again, use a long-lasting suture. Try to put them submucosally if possible. Put as many of the sutures, the knots posteriorly. And then the anterior trachea is brought up against the base of the thyroid ala. Suprahyoid laryngeal releases of the larynxes in this big boy was done, and here's the final anastomosis at the level between the thyroid cartilage and the trachea. This is what he looks like 3 months post-op, decannulated. So, in conclusion, this is a problem for today, mostly of our success in managing very, very sick patients. Prevention is the goal, prevention of prematurity, prevention of intubation, prevention of intubation injury. Much of this today we can manage conservatively, endoscopically, and then reconstructive surgery has a fairly high success rate. This operation essentially put pediatric otolaryngology on the map. And it's one of our great success stories. Areas of investigation, what's the best timing? Do we wait a year? Do we wait 2 years? How do we improve voice outcomes? Are there opportunities for autologous implants? And can we get better control, molecular control of fibrosis? So back to the last step. The first step in stabilizing a child in an ICU setting is getting control of the airway. The last step is getting that tube out. That's what this story was about. Hope you enjoyed the trip through my kind of memory lane about an operation that I've kind of grown up with. I want to thank you for the opportunity to let me share my work with you and be happy to answer any questions.
Is that you and your internship here? You turn the light on, please.
And that's it.
Peter? Okay. So after you do these reconstructions, are kids now still intubated for a week to let the cartilage settle in and the patient can't move and they're only given those respites for neurologic checks and stuff like that? Is it still a week of intubation and ICU stay?
It's a week of intubation. Typically, we seem to do well at a week. 5 days to 7 days. We seem to do well with that. Initially, the first 24 to 48 hours, we paralyze the kids. And then we fly them typically on dexmedetomidine and primarily to cut down on the post-extubation withdrawal symptoms that the kids have from narcotics. It's a big problem with the one-stage reconstruction. Those kids are jittery like this for a week after we get the tubes out. It's nasty to watch. But we've done better with the dexmedetomidine. Yes, Ash?
So when you do the cricottracheal resection, you cut through the cricothyroid muscle, so the voice automatically becomes deeper. Have you found that that is better voice outcome compared to people that have the LTR?
You know, I've heard, my own experience is it's not large enough. Universally, after LTR, the voices are terrible. The voices are not great after cricottracheal resection, but in general they're better. And I think what you've done with the CRI-CTR is you've removed the conus elasticus. The function of the conus elasticus is to guide that airstream to the vibrating surfaces of the cords. When you lose that, you get turbulent vibrations of the turbulent air pushing up against the cords, whether you do it with a LTR or a CTR. You follow? It just, which is more perturbed? I think it's more perturbed with the rib graft reconstruction.
Is there such a thing? Are there LMAs in kids? Are there LMAs in kids now? That the kids get LMAs so they can just
LMAs are great for certain things. 3 months of intubation in the
No, I
NICU
know.
is not one of them.
ICU settings, it's different, but generally speaking, for small cases.
We don't see.
For small cases,
The
you
problem,
can't get
where we see problems are kids who are getting cardiac surgery, and the cardiac anesthesiologists like to put the biggest damn tube down there they can find.
Yeah.
It's an interesting issue because they can ventilate the kids better. I mean, that's their agenda, and we've learned how to work, and sometimes the kid is injured. And the population that's most vulnerable are the kids with cardiothoracic abnormalities, because laryngeal and tracheal abnormalities abound in those kids as well. Let's see, Ed?
Yeah, Peter, I had a question for you about post-op care for the airway after surgery, either CTR or LTP. Do you have a protocol in terms of, say, humidification or inhaled medications to try to facilitate airway healing, cut down on granulation or cast formation? Do you put your patients on anything post-op inhalational-wise?
Have not. Have you?
So when I find, like, for CTR, I have a real problem with fibrin formation in the airway, and sometimes we'll put patients on humidification right after face to try to keep that moist. Some of my colleagues have tried N-acetylcysteine. I don't think that helps. Steroids are a problem, obviously, to give anything systemic right after surgery. And sometimes what we'll do is schedule patients for bronchoscopy to try to clean out this fibrinous exudate that lines the airway. But I've been trying to find a good way to cut down on some of that and haven't found it yet. A colleague, I don't think she's here tonight, recommended aerosolized Ciprodex and said that she heard that
I love Ciprodex.
So do
Use it
you,
all the time.
yeah, do you find that that's helpful for minimizing granulation
Again, we really cut down on the number of kids that we see with tracheitis who have trachs with use of Ciprodex. Okay, do you agree?
It's also been helpful in some of the kids with sliding tracheoplasties who have granulation problems.
And how do you do that? How do you administer that?
Just use the same way as you would do a Toprodex, topramycin nebulizing.
And how do you do that?
You nebulize the drug by RT, and they apply it either through the endotracheal tube or through a CPAP type device.
Thank you.
And you do it every usually 3 times a day, QA. Just RT comes by and does and this is usually easily done in the setting. Joanne?
I was just wondering about deciding whether to do open reconstructive procedures versus endoscopic placement of grafts. Can you just talk a little bit about when you would
I
do
did not, again, that's something I've left out. Andy Inglis introduced the concept of doing a posterior graft. It's been probably a good decade, maybe even 15 years now. And Anna's done all of them here. I've not done one of those. And those are a major advance. And doing things more endoscopically, I think, is the way of the future. Question is, how can we put in an anterior graft endoscopically? Nobody's really worked that out well yet. The posterior graft is now routine, and I think Anna's got a dozen or so kids, if not more. That's regularly done and redone. You can sequentially do a second graft. I should put that in the talk. Anything else? Thank you, everybody.